Other two panelists for the live case, Dr. Mani Vanan and Dr. Samir Kapadia, to join the panel up top. We're ready to go live. They're going to give their talks right after on minimalistic TAVR, Dr. Kapadia, and on imaging for TAVR, Dr. Vanan. I can see already Dr. Sharma, Dr. Kinney, Dr. Kara, Dr. Tang in a patient room there. I don't know if they can hear us and ready to come live to the conference center.
All right. Well, now I would say good morning or just good pre-noon, and this room is working. And sorry for that. It's doesn't take a pride for such a busy lab. And we had the setback this morning, but we deployed the valve with a little bit fluoro came, did it, stop in between, then did remaining with the only with the echo guidance. So we don't have much to show there, but patient has been done. And of course, now we go to case number 3. And this is an 86-year-old. We're going to show the slides now. Patient presented with dyspnea on exertion and class 3 symptoms for last few months. Patient had in the past CAD and PCI and has a surgical valve replacement in 2006 using a 23 millimeter mosaic valve, and then had a reop mitral valve repair and tricuspid valve repair, and the patient has got
AR2 you gave me?
factors.
AR1.
Yeah, so medication-wise, because of the PCI, she has been on, patient has been on dual, he has been on dual antiplatelet therapy, and patient pacemaker dependent. Recently had the PCI of where SVG to DES to RCA. So with that note, we are here now in this particular case, and we'll get the echo. If we can get the slides on, please. Yeah.
Yeah, very complex patient. Let's look at the imaging.
Yeah. Good. Let's see the, yeah. So echo, basically abnormal aortic prosthesis with a high gradient, as you can see, as well as degeneration. The mitral valve repair is good, as well as tricuspid. Those gradients are less than 2, so they're working quite well. So now with the TE, rather than VShow, we'll ask STEM to show the live echo.
Yes,
Put the live echo, please.
You can see we had a hard time putting the regular TE probe, so we had to use a pediatric probe on this patient by anesthesia, put the probe down, and as you can see, the leaflets are moving a bit thickened, but you can appreciate that they're moving good enough. There is some turbulent flow, as you can see in the long view. This is the short axis view again. You can see it's a pediatric probe, but you can see the leaflets moving well, and some again turbulent flow because of the mismatch. The effective orifice area was 0.9, the indexed area was 0.4, so it's severe patient the prosthesis mismatch. The peak velocity was 3.7, peak gradient 55.
Go to another view, LAO.
TVI 0.25, and the acceleration time was 80 milliseconds, so all suggestive of valve prosthesis, and also by looking at the valve, the leaflets are moving, so the patient prosthesis severe mismatch in this case.
Okay, so basically in nutshell, I hope everybody on the same page now, that this is basically looks like a patient prosthetic mismatch, significant ppm, along with that presenting more where the regurgitation, the leaflet itself are moving back. All right, let's go to next slide, please. Okay, so these are the regular transthoracic findings. And now with the CT aortic annulus, and I'll ask Gilbert to talk on that.
Yeah, so this is a mosaic valve, 23 millimeters. So you can see here the inner diameter is a little bit smaller, and also not that easy to get a look at the annulus. The LVOT is a bit larger. Next slide. You can see this is the frame of the eyelets of the mosaic. You can see the sinuses are very generous. Next slide. You can see the STJ is also very large. It's a dilated aorta. You can see here on the bottom 2 panels, the corners are well above the top portion of the mosaic valve, and so the risk of coronary obstruction should be almost 0. So
yeah, because very high.
Yeah, exactly.
25, like 20 to 20 plus.
Yeah.
So clearly, as we talked earlier, and these are all 3 cases have been the degeneration of the the either TAVR or SAVR valve, and this is the third one in that series, in this particular case, were more represented by patient prosthetic mismatch. Vascular access is nothing unusual on this particular case, and arch anatomy.
Yeah, it's clearly tortured. You can see very calcification, so we decided not to proceed with sentinel.
Yeah, now maybe we can ask our panelists, what is the chance that the use of sentinel, we try, as you know, the default approach of sentinel in every case, but still number is about 50%. And we, as you know, as a part of our CATS report, the fellows, they have to document that why sentinel was not used. And they still comes out to be 50% for us.
Well, it's a great topic. We get an opinion from the PI of the trial, Dr. Kapadia, and then a European opinion from Dr. Usia. Dr. Reardon, can I ask you to please come up and give us an opinion right here? You can be with me in the. Oh, that'd be good.
I do want to make one comment. You're calling this patient prosthetic mismatch. This is not patient prosthetic mismatch. This is a structural valve deterioration. Patient prosthetic mismatch implies the valve itself is too small. If you have patient prosthetic mismatch, you probably shouldn't be doing valve and valve to begin with. You need a bigger valve. So we should be very careful with our terminology. This is a structural valve deterioration, not patient prosthetic mismatch.
All right, that's great. I'm sure it's going to come up whether we enlarge a valve or not, but let's hear the quick two opinions of US and Europe regarding the distal protection.
So the Sentinel device...
In this case, I think this is a very important point to discuss. If you go back to the leaflet, they can keep showing the leaflet which is being done. We were told the leaflets are moving quite well, and there is clearly both regurgitation as well as stenosis.
Okay. Samir.
So if we have resolved the question, because I think there is regurgitation and stenosis, so they do agree that there is degeneration of the valve.
Yeah, of course.
The second question is that whether we can put the Sentinel device or not. In the trial, we did exclude about 30% of patients with vascular anatomy. 30%. However, if you look at the current use, at least in our center, we don't pay attention to except for the size, we are not paying attention to the tortuosity and calcification, and we are using it in all patients, and we have less than 5% of the patients that we don't use.
Interesting.
Again, it requires a little bit of experience and a little bit of working with it, but once you get used to it, it's a very simple device to use.
Gianpaolo, what's happening in Europe?
Europe, it's happening that the Sentinel is not so popular. I mean, we are not used to it. So, personally, I'm using only in a very high-risk patient for possibly distal embolization. But in this patient, very old patient, 86 with this anatomy, I don't want to lose more than 5 minutes to place as a filter. So because my incidence of stroke is very, very low, I'm not going to use. I would not use it.
Antonio, what do you think?
It's the same. We only use filters inside the clinical trials.
Raj, what do you think in Los Angeles? We get an opinion from all over the world.
Yeah, so basically our strategy is to use it in every patient. And I think and there are a few patients where you can't use it. So I think in more than 90% of the patients, we actually end up using the device.
Interesting. So we see a lot of variability all over the world, you can see. No wonder. It's very important, though, that there's a very expert site from the United States, the Cleveland Clinic, that don't pay any attention to tortuosity or calcification. They attempted in all the cases that come to them, and they're successful in placing it in 95% of cases without a complication. That's interesting.
And we are going to do a randomized trial. So the randomized trial, Protect TAVR, is going to be a randomized trial. I'm leading it. We are going to have it multi-center, including Europe, and endpoint of stroke. Stroke and death.
How many patients?
Clinical endpoints. Clinical endpoints. No MRI and no neurocognitive analysis.
How many patients you plan to have?
2,400.
Well, that's a big study.
Samir, are you going to include valve-in-valve as well?
Every patient that is commercially all comers.
Any commercial level. That's going to be a very interesting trial. Meanwhile, I see there's attempt to cross with AR2. Maybe needs a little bit bigger, AL1, and we'll see how that goes.
We tried AR2, AL1, and now we have multipurpose.
Yep.
Multi-purpose.
Particularly this valve.
I mean, if we
In other two valve, both of them we crossed with AR1. You saw that was less than 30 seconds, but here...
Yeah, we saw that this is a very large annulus and this and that. I wonder if an AL2 may...
Yes, I agree. AL2 may be
interesting as
helpful.
well. We'll see. That makes a little bit more of a discussion. Let's go back to the aspect of PPM or degeneration. Are these mutually exclusive? Could this valve be both? Could also exhibit some degeneration, but at the same time, since we're doing a procedure, and there may be a component of PPM, could we aim to just replace or place a TAVR in there, or somehow break and enlarge this valve? And is that possible, Dr.
Yeah, so clearly, George, you can start with somebody that has PPM and that valve can degenerate. What I want to be careful about in our semantics is that if you have severe PPM to begin with, putting another valve inside that is unlikely to make that better. And so if you didn't have bad PPM, and this is probably, there may be a little BPM, it's probably high flow from the AR with some degeneration, but it's just the semantics I want to be careful, because I see this mistake all the time. Somebody has a 19 millimeter valve put in there, it's clearly got bad PPM, and a couple years later they're not doing well, and somebody wants to put a TAVR valve inside of it. That's probably not going to solve your problem.
Yeah, I agree with that. On the other hand, if you...
That is the point very well taken, and the whole question there was, we actually got two surgical consultation in this case. It will be his third surgery, and with an 86-year-old, everybody felt that whatever you can do, and the valve, particularly it is a valve which, there are few valves which can be enlarged. This is the mosaic 23 millimeter, which can be fractured, maybe do both, enlarge the valve and then do the TAVR. So that actually is the plan once we cross it.
Well, that's interesting. We just had the talk of Dr. Colombo regarding annular rupture. And let's, Antonio, what do you think about this approach? Would you consider it? What do you think about annulus enlargement and breaking of this bioprosthetic valve ring before the TAVR or in relation with the TAVR? It doesn't matter. Would that make you nervous in any way? What would you say about that? A push.
Have a large experience of breaking the valve. We broke maybe 6 or 7 valves. We never had a complication, but you know, you cannot make statistics out of 10. Samir, you have more experience with these.
I have a lot of experience with breaking the valves, but mosaic is not one of the easy valves to break, just, because the Edwards valve, the one that we saw first, was relatively easy to crack. This is 18-20 atmospheres you have to go, and sometimes they keep balloon rupturing. I think emboli protection is a good idea for the stroke purposes. Annular rupture, I have never seen one. With this, it doesn't happen. But coronary occlusion can happen, or balloon rupture and aortic dissection can happen. We have not had any of that, but I have seen those reported. And Raj has similar experience.
Let's see what's the experience in Los Angeles.
Yeah, so we've done these. I think the risk is in coronary occlusion more than, we've had no issues in terms of aortic root injury, but coronary occlusion we've had times.
And what do you think the indication?
This is a very large annulus, so
Is there any rule that you follow to do the enlargement before the TAVR or after the TAVR?
I think it is safer to do it, after. That's been our approach. But of course, the theoretical disadvantage is that you're already damaging the leaflets with a high-pressure balloon.
Yeah, exactly. Okay, well, it's interesting. Let's.
It's really interesting. George, when we started doing this, we always said don't BAV valve and valve, and now we're doing it on purpose and actually cracking it. So.
Interesting, Antonio.
For situation where we have difficulties to cross the valve, we have been successful utilizing 8 French coronary guiding catheter because it's much more stable. You can orient better. We had some cases where
Looks like AR2 is not so successful over there for crossing. Maybe we revert to JR4, old school.
This is AL. Oh, good.
Very good. As soon as I said that, why was I doing all this time?
No, it's not AR2, AL.
AL2, I'm saying. AL2, yeah, of course. Yeah, but I had to threaten the use of another catheter for it to cross. Always happens like that.
Okay, Stan, just say.
Can we please go to the RAO in order to ascertain the catheter is at the apex?
Right, and also the stem is going to make some point. Stem, yes, you are on.
Yes, I would like to make the point that first there is no AI, because it may look to you that there is AI, but there is no AI at all. And second is that the leaflets may be a little bit thickened, but they open well, completely actually open. So I think it's a little bit degeneration, but I think it's mostly mismatch. And I'm sorry if the image is, we have a pediatric probe, so, but there is no AI at all. Because somebody said that there's a lot of AI, there is no AI at all.
All right.
The leaflets extremely well.
One way is to know that what is the, how old is the valve and what was the hemodynamics before when they put the valve. Because the patient had prior surgeries, right? And at that time, they didn't replace the valve. So it is very likely that at least over time, something has happened to the valve.
Well, most of us have quit using porcine valves in the ventricular aortic positions because the porcine valves are intrinsically obstructive, and most of us go into pericardial. I use them in atrial ventricular positions because they open and close faster, but they really aren't very good in the aortic position from my perspective.
No,
They all tend to be obstructive.
Okay, so now you see the gradient wise.
We don't see the gradient. Can you go to hemodynamics, please? Thank you.
Yeah, right there. Yeah.
So not much gradient.
So we are in good position, not much gradient, and we saw it not much AI. So I think it's a jury out there that it's a combination of both.
Yeah.
Right? Mismatch, and you're right. I mean, I take the clear-cut point of Dr. Reardon that we should not be using this terminology in this particular case if we are presenting so many years down the road. And this
Maybe
years ago, when they did on the work on the mitral valve repair, and so that time there was only 10-12 millimeter gradient, and they left it alone, did nothing to the aortic valve.
So, Samin, we are talking, Alex and I are talking, and we are wondering, does something need to be done at all here?
or at least equalize the transducers, right? Because the aortic pressure is a little bit higher, so maybe the information is not accurate.
Okay, equalize, guys.
Yeah, that's a little bit of a, they may be measuring from the sheath, but we get the idea that clearly the slopes are identical, so not much AS there. And the LVDP is about 18, so that's kind of low. So, there may be some minor adjustments to be made, but we get the idea there.
You see that gradient was so big.
There is such a big difference, right? Now at least you will see something.
Yeah, now we are talking.
There's a gradient of 20.
So we are ready now. Yeah. Okay, right. Anu, tell us what's the plan now.
At least it is more consistent with what you saw on the non-invasive.
True. Yeah.
Let us the 23 true balloon first.
We are going to use a 23.
Can you go to a little bit lower mag so we can see a little bit more of the heart, please? It doesn't project well here. Great.
Good. Yeah, 23 true balloon, because that goes with the inside of or the mosaic valve.
Okay, very well. And now we're doing the exchange so we can place the pigtail in and then the stiff wire.
So I think this is a very important step, and maybe Samir or Raj can comment on it. This extra step taken, going with the floppy wire first and then with the pigtail in exchange to the stiff wire. We actually had 1 or 2 cases of perforation 4 or 5 years ago, 5+ years, and then we changed. Since then, things have been fine. So should it be a routine? And that is what we have been teaching everyone. And it's extra step, yes, but definitely it has prevented only 1 case of perforation happened now in many, many years. This step really has been very helpful.
I think it's a good idea. We don't do it routinely, I think the key is to make sure that when you are coming out with your wire, the the end of the catheter is not digging into the wall of the ventricle.
It's true. Sometimes they say the AL2s or the AR2s, they can very nicely engage the apex in some cases, and then that probably is feasible not to skip this step. But I would say this is probably the minority of cases. Most of the time, you end up somewhere in mid cavity originally, and it's not so clear. You see how nicely this wire curved now in the apex, and we have very secure position. This valve is not so visible as the other prosthetic valves. That's a little bit more of an effort in order to see the valve itself, the three little circles around those clips of the sternum. Hopefully in the working view that we're going to go, this is going to be a little bit better.
Now we need an indiflator to fracture. Once you go up, then you have to close to the patient and then connect this indiflator.
Right, and we have the valve to be implanted ready and checked and all that, of course, in order to minimize the time between the cracking and the implanting.
Yeah, and this one you will use a self-expanding valve, I guess, because we want to put it supraannular.
So what kind of balloon is this? This is the Atlas?
True.
Yeah.
Is essentially a fast inflation, fast deflation, high pressure balloon or whatever, a resistant balloon. And you can see now we went to the working view, and the three little circles are well aligned. We're coaxial, perpendicular to the valve plane, and we don't have the sternum wires in our viewing, and we're ready to pace and slowly go up. The pacing is working now. Still quite high pressure. The pacing is working now, so that is working now, the pacing, so that's a good time to reattempt again. That's a great example, and you can see the dog bone of the balloon and how it's going to expand, hopefully. Let's see. It definitely did expand, this true balloon. Excellent.
Okay, stop pacing, stop pacing.
That was a long pacing run, but I think we needed it. You saw that how it dislodged. And let me also point out that this valve, the little circles are at the top of the stent, or however you want to call it. It's not the annulus. So the annulus was a little bit further south, as you saw it. The patient remains hemodynamically stable. That's very important time now. This is the possibility. This is a possibility of the hemodynamic collapse, and it's not happening, and that's great.
Get the valve.
So the question now is that if, let's say, the valve is functioning fine, should we put another valve inside? This is a question that comes up, because if we just crack the valve.
There's a lot. How much AI is there, Stan? Is there AI?
No, there is AI. Now there's severe AI.
Severe AI, so we have to quickly
fine.
implant the valve. This is our answer. Good question by Dr. Kapadia, and an immediate answer by Dr. Lerakis.
You have the echo there, now you have AI. Before there was no AI. Just want to make the point.
So we made some AI happen. Anyone who might not go for a self-expanding valve, a supraannular implant here in this case? Anybody who would go with a balloon expandable valve? Raj? Doesn't matter?
You've cracked it, so you can use it if you need it, if you are concerned about the coronary, but I think it's for a expanding valve.
Okay, we're entering the LV now. It's a very horizontal entry over there.
I know.
Very horizontal. We're not exactly in yet. We're just at the border zone.
And this is one of the reasons why you would use balloon expandable, that it doesn't want to cross.
Yeah, it is a little bit, we're off the center because it's so horizontal, but it went in. Very good.
Good now.
Now we're in good position, not so high, because remember the annulus is lower than these little things. where is the, you see the annulus is very low.
Which measure they took?
They have the pigtail at the bottom, so.
Consequently, will seem to be somewhat high there.
Okay, good.
So the full
That's probably the right.
is a full pigtail circle below these little markers that the true annulus is.
150.
This is 26, Kini.
20. Yeah, let's take a cine, please, and see, make sure it doesn't pop
Okay,
up.
stop. Inject.
I think it's coming out very good. It may come a little bit higher, but it's...
Stop pacing. It was, it's too low, no?
it could
Yeah, I
come-
think it's a little deep, so you can.
To recapture. Okay, 150.
I think.
I'm going to pull back.
Somehow we don't see very well on the fluoro here, and we just we can't make the end of the stent. We got to go on cine to know for sure what's happening here.
Stop pacing.
Because of patient weight, we can see.
Yeah, let's go on cine.
Okay, do a cine now. Just without it, yeah.
This is much better height.
Yeah, yes. I think we can release now.
Looking good.
Any reason to just keep it there for some time until it expands more, Dr. Makar or Dr. Reardon? Should we keep the valve there for a few minutes in order to expand more? Is what it said?
Well, you're not worried about expanding. If you let it go too soon, they'll often pop out because you
That's
haven't
what I'm
given it
saying.
time. So it's not really so much, it's just letting it find its place.
Right.
But it does that a lot less in valve because it's got that nice frame to hang on.
I would continue the pacing now. So you have always a stable heart.
Ready? Everyone ready?
Can you do it on cine?
Lead on cine.
Yeah, great. Now we can see better. Excellent. That was a great exercise. It aligned exactly the way we wanted it. All right, great.
Okay, cool. Okay, get us a pigtail so we can get the hemo.
Patient seems to be hemodynamically stable, which is very important considering all we saw regarding all we heard regarding possible risks of coronary occlusion. We don't seem to have one of these situations here. This is great. We're going to look at the TE and see if Dr. Lerakis can identify the coronary flow a little bit for us, or some levels there while we are advancing the pigtail in the LV. Any other measure you would do at this point?
There's not much AI. Paravascular, there is some central, but it's because of
But I think hemodynamic assessment will be helpful.
All right. Now just asking, Dr. Sharma, what is the plan? Is there a second case right after, or are we going to lunch?
The plan is very simple. After this, you have 2 more lecture presentations, and then go for lunch.
Excellent.
We'll release you within 1 minute.
Excellent.
So after showing the hemodynamics, we'll release you 2 quick lectures, and then you go for lunch, and by the time we'll be ready with the 2 cases.
We'll see you back at 1:30 then after we end this case. Very well. We're all set to go as you said. Excellent.
No, listen. Wait 1 second. We need to show the hemodynamics.
Yeah, no, we're not going anywhere. We're waiting. I'm just outlining the plan here while waiting.
I see.
We're not going anywhere. I'm just planning ahead here so everybody can be clear of what we expect.
Yeah, would you consider stretching the valve a little bit, post-dilating?
Now we'll use it 26 now or 24 because we used 23 before.
24 true.
You see the coronaries, left main is open.
All right. Is there a reason to do a little bit of a aortogram perhaps?
Pull your T up.
Why don't we do a little aortogram?
Can we do the aortogram?
Yeah. Let's take advantage of this, of the current situation. We see good expansion. You're going to kind of maybe do a contralateral view. Where is Dr. Tang there to guide the no parallax view in 90 degrees? He's not in the room?
I'm trying to recross the valve to give you guys the hemodynamic data, but you can see here the valve is pretty well expanded on this view.
Echo looks good.
Yeah.
Echo looks good.
Yeah, all I'm saying if it's expanded at 90 degrees and we do an aortogram, everybody's happy, why do we might not need to recross here, particularly from the side of the valve. Yeah.
Yeah. The 2-1 view are pretty extreme here. We can get it in a moment. once we get the valve crossed. But you can also see the C-tab is facing one of the eyelets, so I think in terms of curvature alignment, it's also going to be quite favorable for future coronary access.
We're a little bit outside there. Yeah.
Maybe on the other side, posterior.
We'll be on the other side. This annulus is very big. I think we just do the aortogram to guide us a little bit. And do the contralateral view for the frame. Yes, Dr. Tang. I know this is Dr. Tang moving the camera.
There you go. It looks pretty well expanded on the RAO view.
Let's go on cine. Go on cine. We can't see anything. Patient is heavy.
Okay, ready?
Can you move the hemodynamic window to the bottom left, please? Move that window.
Yeah, it looks perfect.
Thank you.
We are done from our side. You're ready for your lectures and then lunch.
I think it looks very good, extremely good. I don't think I would nobody here wants to recross. Excellent.
Good.
We're doing great. A completion of very complex case with enlargement of the annulus and valve-in-valve. And I would like to thank the panel. And we proceed with Dr. Kapadia's talk.